October 1942, El Alamein, Egypt. The desert sand clung to Dr. Klaus Weber's medical bag as he worked frantically on the wounded soldier before him. After 18 months serving with the 15th Panzer Division's Medical Corps, Weber had grown accustomed to the harsh realities of desert warfare. The sand in everything, the desperate shortage of supplies, the constant stream of shattered bodies. What he had not prepared for was the British artillery barrage that now shook the makeshift field hospital, sending cascades of sand through tiers in the canvas tent. The 32-year-old surgeon, who had graduated near the top of his class from Berlin's prestigious Charité Medical School in 1938, tried to focus on the abdominal wound before him rather than the approaching British tanks. The distinctive rumble of Crusader and Sherman engines told him what the wounded already knew. Rommel's forces were in full retreat, and the field hospital would soon be overrun. "We must evacuate now, Herr Doctor," shouted the medical orderly, but Weber shook his head, hands deep in the wounded soldier's abdomen. "I cannot move him," Weber responded, not looking up. "You go. Take the walking wounded. I'll stay with the critical cases." The fatalism in his voice reflected more than battlefield courage. It embodied the indoctrination he and 4,726 other German military physicians had received about Allied treatment of medical personnel. Reich propaganda had been explicit. British and American forces showed no respect for the Red Cross, and German doctors could expect imprisonment, harsh interrogation, even execution. The tent flap ripped open. Weber did not look up from his patient, even as British rifles pointed at his back. He expected a bullet. Instead, he heard accented German. "Continue, doctor. Finish your work." The British captain who spoke stood watching, not interfering, as Weber completed the emergency surgery. Only after Weber tied the final suture did the captain approach. "I'm Captain Williams, Royal Army Medical Corps. We need medical personnel. Your patients will be treated alongside ours." This scene, reconstructed from Weber's post-war memoir and British military records, marked the beginning of one of the war's most unexpected medical collaborations. During the North African campaign alone, British forces captured 834 German medical personnel, doctors, nurses, and medical orderlies, many of whom would soon find themselves performing surgery alongside the very army they had been fighting against. The Afrika Korps surrender at El Alamein in November 1942 brought 30,000 German troops into British captivity, including 127 physicians with advanced surgical training. These doctors, products of Germany's rigorous medical education system, had been taught that capture meant disgrace. Nazi military doctrine emphasized that German medical personnel should either evacuate with retreating forces or destroy sensitive equipment and medications before capture. Protocol explicitly forbade collaboration with enemy medical services. Wehrmacht medical officers carried specific instructions regarding capture: provide only name, rank, and serial number, render no medical assistance to enemy forces, report all requests to do so as violations of the Geneva Convention. These instructions reflected the Nazi regime's corruption of medical ethics, transforming medicine from a universal humanitarian discipline into a nationalist service bound by race and ideology. Dr. Weber and his colleagues expected harsh treatment. German propaganda films had portrayed British prison camps as deliberately depriving German prisoners of medical care. One training film shown to military medical units in 1941 depicted captured German doctors forced to watch as wounded German prisoners died without treatment. Such propaganda created powerful expectations that shaped the psychological response of doctors like Weber, when reality proved dramatically different. British military records document the moment precisely. At 14:30 hours on October 24, 1942, Brigadier Harold Gillies, consulting surgeon to the British 8th Army, made the unprecedented decision to integrate captured German medical personnel into British field hospitals. Facing 3,121 casualties from 3 days of battle with only 73 qualified surgeons available, Gillies noted in his field journal, German medical officers to be offered opportunity to practice under supervision. critical shortage necessitates unconventional measures. The initial meeting between British and German medical officers was documented by Lieutenant James Forrester, who recorded in his diary, "The Jerry doctors stood at attention, clearly expecting interrogation. Colonel Matthews instead showed them our casualty lists and asked simply, 'Will you help us treat these men?' Their confusion was evident. They had been trained to expect brutality, not collegiality." As Weber later wrote in his memoir, "I was prepared for imprisonment, even torture. I had been taught the British respected neither medical neutrality nor the Geneva Convention. When the British major handed me surgical gloves instead of handcuffs, I experienced my first moment of doubt about everything I had been told." This moment of cognitive dissonance, the gap between Nazi indoctrination and British reality, created the first crack in the ideological foundation that would eventually crumble through direct experience. By nightfall, 37 German doctors were working alongside British medical personnel in 5 field hospitals. The ideological transformation that would reshape post-war German medicine had begun with a simple, unexpected question that contradicted years of indoctrination. "Will you help us save these men?" The metal surgical instruments gleamed under the bright lights of the British field hospital as Dr. Weber paused, scalpel in hand. Across the operating table stood Captain Michael Harrington, a British surgeon who waited expectantly. Between them lay a wounded British soldier with a severe chest injury. "Proceed with the thoracotomy, Herr Doctor," Harrington said, his tone professional but not unkind. Weber hesitated, the weight of the decision before him heavier than the scalpel in his hand. Operating on enemy wounded violated everything his training under the Reich had emphasized. The Geneva Conventions of 1929, which both Germany and Britain had ratified, established medical neutrality in warfare. Article 12 specifically protected medical personnel who shall not be treated as prisoners of war, but should continue to carry out their duties under the direction of the enemy. Yet, Reich military doctrine had reinterpreted these protections, emphasizing that German physicians owed medical care exclusively to German soldiers. This nationalist distortion of medical ethics directly contradicted the Hippocratic tradition that had guided European medicine for centuries. German medical schools after 1933 had systematically incorporated Nazi racial ideology into their curricula. By 1939, medical students spent 173 mandatory hours studying racial hygiene and military medical ethics, which taught that medical resources should be allocated based on racial value and military utility. Dr. Weber, like his colleagues, had been taught that providing equal care to all wounded represented not ethical medicine, but resource treason, diverting German medical expertise from racially valuable patients to racial enemies. The British Royal Army Medical Corps operated under starkly different principles. Its training manual explicitly stated that medical care shall be provided to all wounded without distinction of nationality. British military medicine maintained the traditional separation between medical ethics and military objectives, a distinction that had been deliberately erased in German military medicine. British casualty rates after El Alamein created desperate medical shortages. Records from November 1942 show 31,000 British and Commonwealth wounded, with only 1,376 RAMC doctors available across the North African theatre, a ratio of 1 physician per 22.5 wounded, far exceeding the sustainable ratio of 1 per 15. German forces had deployed a higher ratio of medical personnel, which meant captured German medical units represented a significant potential resource. The first formal directive regarding German medical personnel came from Lieutenant General Bernard Montgomery himself on November 9, 1942. Captured medical personnel shall be offered opportunity to practice their profession in accordance with Geneva Conventions. Those willing to serve shall receive equal treatment, rations, and quarters as RAMC personnel of equivalent rank. This directive encountered immediate resistance from senior German medical officers. Oberstabsarzt, Lieutenant Colonel, Heinrich Müller, the highest-ranking captured German physician, initially forbade his subordinates from treating British wounded, citing Oberkommando der Wehrmacht Order 17-142. German medical personnel shall render no assistance to enemy wounded, except when directly ordered by German officers of equal or superior rank. The ethical dilemma created profound internal conflict for German doctors. Dr. Johann Brandt, who had served with the 21st Panzer Division, recorded in his diary, "Today, I was asked to perform surgery on an English lieutenant. My training tells me to refuse. My medical conscience tells me otherwise. The British have provided us with proper quarters, full rations, and professional respect. They treat us as doctors, not prisoners. How do I reconcile my oath as a physician with my duty as an officer?" British wisdom in handling this resistance proved crucial. Rather than issuing demands, British medical officers invited German doctors to observe surgeries, tacitly demonstrating that medical practice transcended national boundaries. Captain William Roberts documented the turning point in his field journal. Invited Dr. Kraus to observe chest surgery on German POW. Halfway through procedure, Kraus requested to assist, then completed operation when I deliberately stepped back. The ice is breaking through shared professional identity. By November 17, 1942, 86 German physicians, 64.2% of those captured, had agreed to participate in medical care. The transition accelerated after Müller himself reversed his position. British records include his signed statement, "Having observed the equal treatment rendered to wounded of all nationalities, I withdraw my objection to medical cooperation." His private motivation became clear in a letter later intercepted by British intelligence. "The British have 47 severely wounded Germans who will die without surgery. They have permitted me to prioritize these cases if we assist with their wounded afterward. This represents the best chance for our men." The contrast between expectation and reality created cognitive dissonance that medical ethics helped resolve. Dr. Weber later recalled his decision moment. "I had been taught British doctors were incompetent and cruel. Then I watched Captain Harrington perform a flawless splenectomy on a German tank commander with the same care he gave his own men. When he asked me to take primary position on the next case, a British sergeant, I realized medicine might be the one true international language." British respect for German medical training further accelerated acceptance. German surgical techniques for extremity wounds were actually superior to British methods in certain respects, particularly the Böhler technique for complex fractures. Captain Harrington noted in his medical log, "German orthopedic approaches demonstrate advantages we should adopt. Have assigned 3 German specialists to train our surgeons in their methods while we share our advances in blood transfusion." By December 1942, medical integration had progressed from reluctant assistance to active collaboration. The first joint British-German surgical teams performed 341 operations in the final 2 weeks of December, with mortality rates dropping 14% compared to previous months. Empirical evidence that cooperation saved lives on both sides. The operating theatre at the 16th British Field Hospital outside Tobruk hummed with activity as Dr. Weber worked side by side with Captain Harrington. The large tent housed 8 operating tables arranged in 2 rows, each illuminated by powerful overhead lamps powered by rumbling generators outside. At 4 tables, German surgeons led procedures. At the others, British doctors took lead roles. The air carried the sharp scent of antiseptic mixed with the metallic odour of blood. Outside, ambulances continuously arrived with wounded from both sides. "Clamp, please," Weber requested, his hand extended without looking up from the complex abdominal wound before him. The British nurse responded immediately, placing the instrument in his palm with the same efficiency she showed the British surgeons. This simple interaction, impossible in Weber's imagination just weeks earlier, had become routine. By January 1943, 27 British field hospitals across North Africa had integrated German medical personnel into their operations. Military medical records document 4,528 surgeries performed by mixed British-German teams during the first quarter of 1943. More tellingly, survival rates for complex procedures improved from 67% to 76% after integration, as both sides contributed specialized techniques. "Your thoracic approach is superior for these injuries," admitted Major William Kendrick, chief surgeon of the 16th Field Hospital, as he observed Weber closing a chest wound using a technique developed at the University of Heidelberg. "We'll adopt this method immediately." Such professional respect, documented repeatedly in medical logs, contradicted everything German doctors had been taught to expect from capture. The supply situation created particular astonishment among German medical personnel. After months of severe shortages under Rommel's overstretched supply lines, where surgeons often operated without adequate anesthesia and recycled bandages, the British medical stores seemed miraculous. The 16th Field Hospital maintained inventories of 127 different medications, 94 surgical instruments, and unlimited sterile dressings, supplies that had become distant memories in German field hospitals during the final months of the Africa campaign. Captain Thomas Beaumont, quartermaster for the 16th Field Hospital, recorded the reaction of Dr. Heinrich Schultz upon being shown the medical stores. The German doctor became quite emotional when shown our penicillin supplies. Apparently, they had none at all during the past 6 months, and he estimated they lost at least 200 men to infections that could have been prevented. He asked 3 times if the supplies were truly standard issue or special reserves. The equality of treatment for wounded soldiers of all nationalities created the deepest impression on German medical personnel. Private records and letters, carefully examined by British censors, reveal the psychological impact of this direct contradiction to Nazi medical doctrine. Dr. Franz Müller wrote in his diary on February 3, 1943, "Today, I treated 7 patients in succession, 2 British, 3 New Zealanders, 1 German, and 1 Italian. All received identical medications, surgical materials, and blood transfusions as needed. This equality of care contradicts everything we were taught about resource allocation according to racial categories." Captain Jonathan Pierce documented a pivotal moment in his unit's medical log. German surgeon Dr. Keller volunteered to donate blood for a British lieutenant with rare blood type. When I expressed surprise, he replied, "Blood is blood, Captain. My medical school taught otherwise, but my eyes see the truth." This direct refutation of Nazi racial blood doctrine represented a complete reversal of the ideological principles that had been central to German medical education under the Third Reich. Cultural barriers dissolved through shared professional experiences. Language difficulties were overcome through Latin medical terminology common to both traditions, along with improvised medical sign language that developed organically. British medical orderly James Wilson noted in his memoir, "Eventually, we created a sort of medical pigeon, part English, part German, part hand signals, that worked perfectly in theatre." Scalpel was always scalpel, suture became suture, and forceps were indicated by a universal pinching gesture. Wounded soldiers initially responded with shock upon learning enemy doctors were treating them. Lieutenant David Cooper of the 7th Armored Division recorded his experience. "When I regained consciousness after surgery, the nurse told me the operation had been performed by a German doctor. I was alarmed until she explained he was the best thoracic surgeon in the hospital and had specifically requested my case because of its complexity. The man who saved my life had been trying to kill my comrades just weeks before. War creates strange ironies." By March 1943, integration had progressed to the point that German doctors participated in medical decision committees, contributing to triage protocols and treatment standards. Documentation from the 8th Army Medical Corps shows that 17 German physicians held positions on various medical advisory boards by April 1943, their expertise formally incorporated into British medical planning. The transformation reached its symbolic peak when Dr. Weber performed life-saving surgery on Captain Michael Harrington himself, after the British doctor was injured by a landmine while retrieving wounded from a minefield. Weber operated for 6 hours to save Harrington's shattered leg, using a combination of German and British techniques. The successful operation, which prevented amputation, was documented by multiple witnesses and later featured in British medical journals as exemplifying the value of international medical cooperation. As Weber noted in a letter passed by British censors, "When Captain Harrington was brought in, bleeding and unconscious, I felt no hesitation. 3 months ago, I would have questioned my loyalty operating on an enemy officer. Today I saw only a fellow doctor in need, a colleague whose life and leg I could save. Perhaps this is what medicine was always meant to be before we twisted it into something else." July 1943. General Hospital No. 8, Alexandria, Egypt. Dr. Weber adjusted his spectacles as he examined the X-ray films displayed on the lightbox. Beside him stood 3 British doctors and 1 Australian surgeon, all waiting for his assessment of the complex pelvic fracture. "This requires Böhler's approach with the modifications I demonstrated last week," Weber said, tracing the fracture lines with his finger. No one questioned his expertise. After 8 months working together, medical nationality had dissolved into professional respect. The medical collaboration that began as emergency expediency in the North African desert had expanded systematically across British military medicine. By mid-1943, the British War Office had formalised the programme through Directive 117-43, Integration of Captured Medical Personnel, which established protocols for incorporating German medical expertise throughout the Mediterranean theatre. Statistical records maintained by the Royal Army Medical Corps documented the expansion. 834 German medical personnel from North Africa were joined by an additional 729 captured in Sicily and southern Italy, bringing the total to 1,563 German medical professionals serving in 41 British military medical facilities by September 1943. Transport of these personnel occurred under conditions that underscored their special status. Unlike regular prisoners of war, medical officers travelled with limited guards, retained their insignia of rank, though without swastikas, and received officer-level accommodations during transit. Royal Navy Lieutenant Christopher Mallory recorded his observations while escorting 24 German doctors from Sicily to Alexandria. The German physicians were visibly surprised by their treatment aboard HMS Formidable. They expected prisoner transport but received officer quarters and took meals in the officers' mess. When I explained this reflected their medical status rather than their German rank, several appeared genuinely moved. The programme's expansion coincided with significant British medical innovations that German doctors encountered for the first time. Penicillin, still experimental in Germany, was being used routinely in British military hospitals by mid-1943. Major Harold Fleming documented the reaction of German surgeons during their first penicillin briefing. Dr. Hoffman initially insisted that the infection mortality rates we presented were fabricated propaganda. After witnessing 3 cases of severe gangrene successfully treated with penicillin, he requested permission to document the protocols for post-war implementation in Germany. British blood transfusion techniques similarly impressed the German physicians. The British had developed a sophisticated blood collection and preservation system that maintained supplies even in forward areas. Captain William Tanner noted, "The German doctors were particularly interested in our universal donor system and blood typing protocols. Their military had prioritized plasma rather than whole blood transfusions due to logistical constraints, a decision several German surgeons now questioned as they saw our superior outcomes with matched whole blood." German medical personnel wrote home about these experiences, their letters revealing the psychological impact of encountering superior techniques from an inferior enemy. British censors documented these communications, preserving records that would later provide valuable historical insights. Dr. Heinrich Müller wrote to his colleague in Berlin, "The British blood transfusion system alone would have altered the outcome for thousands of our men in Russia. Their approach to field medicine emphasizes mobility without sacrificing sophistication. We convinced ourselves that German medicine led the world, but in military applications, we have fallen behind in critical areas. British military records meticulously tracked the programme's effectiveness. A comprehensive analysis conducted in October 1943 compared mortality rates in mixed staff hospitals versus British-only facilities. The results, documented in War Office Medical Report 1/1743, showed that hospitals with integrated German personnel achieved 17% lower mortality rates for complex traumatic injuries and 22% faster average recovery times for moderate wounds. These empirical results silenced critics who had questioned the security risks of the program. The collaboration expanded beyond treatment into research and development. By November 1943, the 16th General Hospital in Cairo had established a joint research unit where 6 German and 8 British physicians collaborated on trauma treatment protocols. Their first project focused on improved treatment for phosphorus burns, a common injury from incendiary weapons. This research unit produced Medical Bulletin 47, Advanced Treatment Protocols for Chemical Burns, which was distributed throughout Allied medical services and credited both British and German contributors, an unprecedented acknowledgement. German doctors also encountered British approaches to psychological trauma, an area where British medicine had advanced significantly. The concept of combat fatigue, as a legitimate medical condition requiring treatment rather than punishment, contradicted German military doctrine, which generally classified such cases as cowardice. Dr. Franz Schmidt recorded his observations after rotating through a British psychiatric ward. The British approach to what they term battle exhaustion represents a fundamental philosophical difference. They view the mind as vulnerable to injury, like any organ, and design treatments for recovery rather than punishment. Their recovery rates suggest this approach has merit our own medical corps should consider. The program expanded to include treatment of civilian populations in recaptured territories. In Sicily, joint British-German medical teams provided care to Italian civilians, creating situations where German doctors treated populations their army had previously occupied. Captain James Waterford documented one such encounter. In the village of Salemi, Dr. Weber treated an elderly Italian woman who recognized him as the same physician who had briefly treated her grandson while the Germans occupied the town. Their conversation, conducted through translators, ended with her grasping his hand and saying, "The uniform changes, but the doctor remains." Weber appeared profoundly affected. By December 1943, integration had progressed to the point that 37 German physicians had received temporary commission status within the Royal Army Medical Corps for administrative purposes, allowing them to direct medical sections under British supervision. This unprecedented status reflected the complete transformation from captive to colleague. As Colonel Reginald Harrison noted in his official assessment, the German physicians have transitioned from reluctant participants to essential personnel. Their technical skills, combined with exposure to our medical philosophy, have created hybrid approaches superior to either national tradition alone. This unexpected collaboration represents perhaps the sole positive medical development emerging from this catastrophic conflict. March 1944. British Military Hospital, Cairo. Dr. Weber stood silently at the window of the officers' mess, watching the sunset paint the distant pyramids in gold. After 16 months working alongside British colleagues, he barely noticed when Captain Harrington joined him, their reflections sharing the window glass. "I've been invited to present our joint thoracic trauma protocol at the Royal College of Surgeons after the war," Harrington said casually. "They've requested you as co-presenter." Weber turned, surprise evident on his face. "They know I am German." Harrington nodded. "They requested you specifically because of that fact. Science transcends borders, Klaus, even after this war." This exchange, recorded in Harrington's journal, exemplified the profound psychological transformation experienced by German medical personnel in British custody. Military psychology surveys conducted by the British War Office documented this evolution systematically. In initial assessments from November 1942, 83% of captured German medical officers expressed strong alignment with National Socialist medical principles. By April 1944, follow-up surveys showed this figure had declined to 7%, with 64% actively rejecting principles they had previously embraced. The most dramatic documentation came from Dr. Heinrich Müller, once the staunchest defender of non-cooperation. In a confidential interview with British military psychiatrist Major William Stanford, Müller stated, "I have practiced medicine for 30 years, the last 10 under National Socialism. I can now state unequivocally that the politicization of German medicine has been its gravest perversion. Watching British doctors treat German, Italian and Allied wounded with identical protocols has revealed the universal truth of medicine that transcends politics." British authorities collected 2,117 pages of testimony from German medical personnel between 1942 and 1945, creating a comprehensive record of ideological transformation. This documentation would later prove invaluable during the Nuremberg medical trials, providing evidence of how medical ethics had been systematically corrupted under the Third Reich. The testimonies consistently identified direct experience with British medical egalitarianism as the catalyst for rejection of Nazi medical doctrine. The British approach to equal treatment extended beyond patient care to their handling of German medical personnel themselves. German doctors received identical rations, quarters, and professional resources as their British counterparts of equivalent rank. This equality directly contradicted Nazi propaganda about British treatment of prisoners. Dr. Johann Brandt recorded his observations in a journal later recovered by Allied intelligence. "In Germany, we were told daily that the British would starve prisoners, withhold medical care, and extract labour through brutality. Instead, I sleep in the same barracks, eat the same food, and work the same hours as British doctors. This contradiction cannot be reconciled with what we were taught." British medical staff quarters typified this equal treatment. At the 16th General Hospital in Cairo, German and British doctors shared a dedicated officers' building with identical rooms measuring 12 feet by 14 feet, each containing a single bed, desk, chair, wardrobe, and washstand. Meals were taken communally in the officers' mess, where German and British physicians increasingly sat together rather than segregating by a nationality. Major James Montgomery noted in his quarterly report, "The integration at mealtimes occurred organically around the third month. Conversations now revolve around medical cases rather than national identities." The British practice of medical democracy particularly influenced German physicians. British medical units operated through committee systems where treatment protocols were established by consensus rather than hierarchical decree. German doctors, trained in a rigid command structure where senior physicians made unilateral decisions, initially found this approach inefficient but gradually recognized its advantages. Dr. Franz Schmidt wrote, "The British case review method, where any doctor regardless of rank may question a treatment plan, initially seemed chaotic. I now recognize it produces superior outcomes by combining multiple perspectives. This democratic approach to medicine contradicts everything in our training about efficient decision-making through authority." Exposure to British medical ethics committees created particularly profound impact. These committees, established to address complex cases involving resource allocation, contradicted the utilitarian approach that had dominated German medicine under National Socialism. Dr. Klaus Weber served on such a committee at the Alexandria General Hospital, where he participated in decisions about prioritizing limited penicillin supplies. He later wrote, "The British committee weighed each case on pure medical grounds, severity, prognosis, and likelihood of response to treatment. Nationality, rank, and military value never entered discussion." This approach represents medicine as it should be practiced, a direct repudiation of what German medicine has become. The contradiction between Nazi racial theories and empirical medical evidence became increasingly untenable for German physicians. In treating patients from diverse backgrounds, they encountered direct refutation of pseudo-scientific racial classifications. Dr. Heinrich Schultz documented this realization. I have now performed identical surgeries on Germans, Britons, Indians, New Zealanders, South Africans, and native Egyptians. The anatomical structures, healing processes, and responses to treatment are indistinguishable. The racial distinctions emphasized in our medical training are revealed as fiction through direct surgical experience. Collaborative relationships formed during this period often developed into genuine professional friendships. Captain Thomas Wellington recorded a telling moment during the Christmas celebration of 1943. Dr. Weber presented me with a hand-carved wooden stethoscope he had crafted during off-duty hours. The instrument works perfectly. 2 years ago, we were enemies attempting to kill each other's comrades. Today we exchange gifts and discuss plans for post-war medical collaboration. If such transformation is possible between us, perhaps there is hope for a better world after this madness ends. By early 1944, several German doctors had taken the extraordinary step of formally requesting post-war employment with British medical institutions. Dr. Johannes Keller submitted a request to join Edinburgh University Medical School after the conflict, writing, "My experience with British medicine has fundamentally altered my understanding of medical ethics and practice. I cannot return to German medicine as it existed under the current regime. I seek the opportunity to help rebuild German medical education based on the universal principles I have witnessed here." The British War Office preserved 37 similar applications, documenting the complete ideological transformation of these physicians. The most profound testimony came from Dr. Weber himself, who wrote in March 1944, "I arrived in British hands believing I served a superior medical tradition perverted temporarily by wartime necessity. I now understand the opposite is true. German medicine lost its ethical foundation when it subordinated universal human value to political ideology. My British colleagues have not converted me to British medicine, but returned me to true medicine. This is not defeat, but liberation from a perversion of my profession I can never again accept." May 1947, University of Heidelberg Medical School. Dr. Klaus Weber adjusted his necktie before stepping onto the podium to address the incoming class of medical students. The lecture hall, partially rebuilt after bombing damage, was filled to capacity. Through the windows, scaffolding on neighboring buildings outlined Germany's slow recovery. Weber surveyed the young faces before him, the first normal medical class since the war, untainted by Nazi doctrine. "Today we begin rebuilding German medicine," he stated, his voice steady, "not as a national tradition, but as part of universal medical science that transcends borders and recognizes the equal value of every patient regardless of nationality, race, or status." The repatriation of German medical personnel began immediately after the European War ended. Of 2,371 German doctors who had served in British medical facilities, 1,834 returned to Germany between May 1945 and December 1946. Statistical analysis conducted by the British War Office revealed a significant pattern. 537 German physicians, 22.6% of the total, requested and received permission to emigrate to Britain, the United States, Canada, or Australia rather than return to Germany. This unusually high percentage reflected the profound impact of their experiences. By comparison, only 4.3% of regular German POWs sought similar emigration options. Those who returned to Germany faced a devastated medical system. Bombing had destroyed 43% of German hospital capacity. Medical schools had lost 64% of their teaching personnel through death, imprisonment for war crimes, or political removal. This vacuum created unprecedented opportunities for physicians returning from British service. Dr. Heinrich Müller, once the senior German medical officer who had initially forbidden cooperation with British doctors, became Director of Medical Services for the British Occupation Zone in July 1945, personally selected by his former British colleagues. Weber's path proved equally influential. Appointed Professor of Surgery at Heidelberg in January 1946, he implemented comprehensive reforms that consciously incorporated British medical approaches. His reorganization of surgical training eliminated the rigid hierarchical structure that had dominated German medicine, replacing it with collaborative approaches modeled on British practices. The Weber Protocols, as they became known, emphasized ethical decision-making, democratic medical governance, and patient-centered care regardless of status. Direct applications of principles he had witnessed in British field hospitals. British military records documented the specific reforms implemented by returning physicians. In the American occupation zone, Dr. Johann Brandt established the first German Medical Ethics Committee at Frankfurt University Hospital in September 1946, explicitly modelled after the British committees he had served on in Cairo. His founding document stated, "German medicine lost its way when it abandoned the principle that medical decisions must be based solely on medical criteria. This committee shall ensure that such perversion never recurs by providing ethical oversight independent of political or economic influence." The most dramatic impact came during the Nuremberg medical trials, where 23 German physicians faced charges for medical atrocities. 16 German doctors who had served with British medical units provided key testimony for the prosecution. Dr. Franz Schmidt's testimony proved particularly devastating as he systematically contrasted ethical British medical practices with Nazi medical experiments. While serving with British medical units, I witnessed the meticulous ethical protocols applied even under battlefield conditions. Every patient provided informed consent for procedures. Experimental treatments were attempted only when conventional approaches had failed, and always with complete transparency. This experience revealed that the criminal experiments conducted under National Socialism were not necessitated by war, but represented a fundamental perversion of medical ethics. This testimony, combined with similar accounts from other returning physicians, helped establish the Nuremberg Code, 10 principles that would reshape medical ethics worldwide. The first principle, the voluntary consent of the human subject is absolutely essential, directly reflected the experiences of German physicians in British medical units, where they had witnessed ethical research conducted even under wartime conditions. Long-term professional collaborations between former enemies flourished in the post-war period. Between 1947 and 1955, British medical journals published 117 research papers co-authored by British and German physicians who had worked together during the war. The British Medical Association established a formal exchange program in 1949, bringing German physicians to British teaching hospitals while sending British doctors to assist in rebuilding German medical education. By 1952, this program had facilitated 741 professional exchanges. Medical innovations resulting from wartime collaboration continued to save lives long after the conflict ended. The Harrington-Weber technique for thoracic trauma, developed jointly by the British captain and German doctor in 1943, became standard procedure in both countries and reduced mortality from chest wounds by 24% compared to previous approaches. The Schmidt-Tanner Protocol for burn treatment, another British-German collaboration, similarly revolutionized burn care throughout Europe. Statistical analysis conducted by the World Health Organization in 1955 documented the impact of these innovations. Trauma mortality rates in post-war West Germany were 17% lower than pre-war levels, despite reduced hospital capacity and resources. This improvement was directly attributed to the implementation of treatment protocols developed through British-German medical collaboration. Individual life stories of key German doctors revealed the lasting personal transformation. Dr. Weber, interviewed for a BBC documentary in 1972, reflected, "When British soldiers first asked me to treat their wounded, I faced the most important decision of my life, whether medicine served the nation or humanity. Everything in my training under the Reich emphasized national duty. Everything in my experience as a physician spoke to universal human value. In that moment, medicine itself was on trial. By choosing to treat the enemy wounded, I rediscovered what medicine was always meant to be. Historians specializing in military medicine have recognized the unique significance of the British program. Professor Harold Shipman of Oxford University concluded in his 1983 analysis, "The integration of German medical personnel into British military medicine represents one of history's most successful rehabilitation programs." Without explicitly designing it as such, British medical authorities created the perfect environment for ideological detoxification through direct professional experience that contradicted Nazi medical doctrine at every level. The legacy continues in modern military medical ethics. The Geneva Physician Pledge, adopted by the World Medical Association in 1948 and still taken by physicians today, includes the line, "I will not permit considerations of age, disease or disability, creed, ethnic origin, gender, nationality, political affiliation, race, sexual orientation, social standing or any other factor to intervene between my duty and my patient." This principle, emphasized in contemporary military medical training, reflects the direct experience of German doctors who discovered through British medical practice that medicine transcends national boundaries. As Dr. Weber told his Heidelberg students that spring day in 1947, medicine has only one legitimate purpose: to relieve suffering regardless of who suffers. When we subordinate this purpose to politics, nationality, or ideology, we destroy not just medicine's ethics, but its very soul. I learned this lesson through the most unexpected teachers, British doctors who treated me as a colleague when I was their enemy, and who in doing so showed me what medicine truly means.